male reproduction and erectile dysfunction. We're going to review the anatomy, review physiology, the 4 stages of sexual response, and then manifestation of ED as well as corrections for ED. How does PDE inhibitors work? How does PDE inhibitors work? Okay, so block phosphodiesterase. Okay, so that's the consensus. Good. So penile anatomy, the penile tissue, there's 3 corporal bodies. The corporal cavernosa is the erectile tissue body, and the spongiosum is around the urethra. And then the urethra is here centrally. And then you have the cavernosal arteries here and here. And then this is the dorsal vein. So when the erectile bodies are engorged, it compresses the dorsal vein, which maintains the erection. The deep fascia of the penis. So there's a Buck's fascia, which is, I'm going to show you soon, is this one. And then you have the tunica albuginea, which is this structure. It's wrapped around the cavernosal bodies. That's the green tunica albuginea. That's the one that gets torn in the setting of penile fracture. And then the deep dorsal vein is in orange. So when then that gets compressed during erection, which is normal. And during the flaccid state, it's open, or it's patent, and allows the veins to drain normally. That was supposed to be an animation. Penile skin. So it's innervated by the pudendal nerve, which is S2 through S4, not L2 to L4. And there's a higher concentration of the nerve endings at the glans penis, which increases the sensitivity. So that physical stimulation then leads to arousal. Penile contains, so the answer to this question is false. It's not L2 to L4, it's S2 to S4. There are 4 stages of the sexual response. First is the excitement, the plateau, orgasm, and then resolution. So we'll go through the different stages. The response is from the autonomic nervous system, parasympathetic plexus of S2 through S4, and then sympathetic, lower thoracic and upper lumbar. This is the first aid way to remember it, which is point and shoot. Parasympathetic is involved in erection, and the sympathetic is involved in ejaculation. There's also sensory nerve that's provided from the pudendal nerve, S2 through S4. So it's a combination of autonomic as well as sensory and motor. So the second phase, excitement, is it can be multiple sources: olfactory, visual, auditory, memory, emotional, physical stimuli. And it's not really quite known, it's not known what the neurostimulators are, or neurotransmitters are that regulate this process, and it's associated with systematic physiological response. So yeah, like tachycardia and whatnot, increased heart rate, respiration, blood pressure, and then you have muscle contraction and vasodilation with engorgement of the genitals. So there are corresponding male and female responses, physiological responses. Men, they get erection, scrotal vasocongestion, testicular elevation, and a similar response occurs in women. They get increased lubrication, contraction of the uterus, and the vagina lengthens. The third phase is a plateau that in women, the clitoris retracts, and then there's vaginal swelling. And in men, that's when the pre-ejaculatory secretion gets released from the bulbourethral glands. And then orgasm, that's when the male counterpart, there's ejaculation, and then that's the oxytocin is released. Similarly, with a woman, there's contraction of the vagina, which these responses sort of just help the sperm transport into the uterus. So when there's mishap of this process, this can lead to erectile dysfunction, and this sort of correlates with age. As men get older, there's a higher prevalence of ED. Diabetes increases the risk of ED because of vasculopathy. It's a vascular disease, and so it's an inflow problem. In contrast, psychological disorders such as depression increases the risk of ED, and it's more like psychiatric impact more than, say, a structural problem like diabetes, where we have microvascular disease. Diagnosis and evaluation, because there's so many different contributing factors, people who specializes in ED, so urologists and whatnot, you have to go through a very extensive history. Medical history, we said, right? Anything that increases vasculopathy will increase risk of ED because of the inflow problems. So they've shown that if a man presents with, erectile dysfunction, he is at an increased risk for developing acute coronary syndrome within a few years of ED. And it's because of the underlying condition, which is arteriovascular disease. And then you want to go through sexual history, because there are structural problems like Peyronie's disease that causes abnormal curvature of the penis, that can, lead to problems with intercourse. And so, understanding the quality, timing, and then also like assessing the physical structural changes is important. And there's the Erectile Function Questionnaire, which assesses the quality of life and its impact, and it's used to then, that quality of life survey is measured over time as the patient's getting treated. Risk factors, we mentioned earlier that age predisposes to ED, but anything that causes vasculopathy, so cardiovascular disease, cigarette smoking, diabetes, hypertension, hypercholesterolemia can also lead to ED because of the inflow problem from our arteries. And then also treatment to the pelvis. So patients who've had prostatectomy have the pudendal nerves resected during surgery. So they develop post-operative erectile dysfunction from nerve issues. And then hormonal problems. So men who are on exogenous steroids for muscle building, for example, will develop hypogonadism, which then leads to erectile dysfunction. There are lots of meds that can contribute to erectile dysfunction. Analgesics, opiates, all antidepressants, anti-seizure medications, and any of like the, Benadryl and whatnot. Diagnosis and treatment. So just like anything, we need to do a pretty extensive H&P, and then go through the different parameters and factors that can lead to ED. So sexual, psychological, social history, if they're taking steroids, for example, and then have them complete the questionnaire so you know where they are and what their baseline is. Do lab studies, total testosterone, as well as other parameters, lipids and what that can, it's related to vascular disease, TSH, because hypothyroidism can lead to ED. So then these are the known definable medical causes of ED, and depending on the extent of ED, there's different kinds of treatment, both medications, which is usually how it started, and then more aggressive interventions like penile implants. And then, of course, there's like sort of the non-definable medical causes, so psychological conditions and factors like depression that are harder to manage and treat. So typically, first line, if you know what the causative agent is, then you're going to address that immediately, remove medications that might be leading to ED or change the meds, and then you start off with oral PD inhibitors. And then If they have hypogonadism, you can give them testosterone supplements to normalize their testosterone. If oral medications fail, then you can then do more aggressive treatments. So you can do injection of alprazolam and vacuum pump. Both of these require manual dexterity. So if they don't have it, then it'll be much harder to do. And if this fails, then the patients can get penile implants. And there are different types depending on the patient's condition, and we'll review some of that. So PDE phosphodiesterase inhibitors, the way it works is it's on the receptor on the cell membrane, and it keeps the penis from becoming flaccid. So it's, you guys probably are a lot more familiar with this than I am, but it's been a long time since I've done biochemistry, but it increases the cellular cGMP. It blocks the conversion of that into its byproduct. So it increases this concentration, which then maintains erection. So how does this work? I think most of you guys answered it correctly. It blocks the phosphodiesterase on the cell membrane, which increases the cGMP concentration intracellularly and maintains erection. The medication was originally developed for a different condition, I think cardiac, and then they found out that during the clinical studies, as they were giving these medications, there was this unintended side effects, which was erection. So then it was then remarketed as an erection medication rather than its original intention, which was something else, like completely different. So we start off medications. There's several forms. So oral is, the least invasive, and if that doesn't work, then you can do direct injection of vasodilators, and individually or in combination, which increases the vasodilatory effects and reduces the flaccid, sort of the decompression of the cavernosal body. And if these fail, then patients can get mechanical implants. And there's two forms, semi-rigid and rigid. So mechanical treatment for ED is, I think most of you guys got that, is the implants. The other ones are not, they're medications. They're not surgical mechanical interventions. So there's, so we'll go into how this is done. Oh my, okay. This was a video that showed how you injected the intracorporeal meds. So, and unfortunately it's not working, but you have the medications, and then you, like a small caliber syringe, sort of like a TB needle to do skin testing, and then you inject that directly into the cavernosal bodies. There's a question. Under sexual history, partner sexual function, is that related to depression? Partner sexual function. That's a very good question. So partner sexual function could be related to depression. So anything that could interfere with the patient's partner, so psychological, and even the patient, like the patient's partner, they can have structural problems that interfere with, proper intercourse. So under partner's sexual function, it's, it's sort of exhaustive. So when men go in to get evaluated for erectile dysfunction, the partners are usually assessed as well to exclude that as the contributing cause. Okay, so mechanical devices. So this is the vacuum pump, and it's placed into the penis, the entire length, and then you put this ring at the base of the penis, and then you pump to increase the vascular engorgement. And then you keep the ring in place at the base during the erection, and then it's removed after intercourse. Surgical implants, there's different types. This is called a semi-rigid. Semi-rigid is inflatable. So here's a good example. The corporal bodies, this one is placed into the penis surgically. It is a pretty simple procedure. It's like 2 hours. And then once it's placed, then there's a pump. There's this little lever here that the patient hold onto, and then they push onto it. And as they push on that, it then releases the water that's in the reservoir that's placed retropubically, and the water then goes into the rods, so it inflates it. And then this is what they're doing. This is how they do it. So they pump, and then it causes the erection for the penis. And obviously, this is going to require manual dexterity. So if the patient does not have that capacity, then this is not an appropriate therapy for them. This is an alternative therapy for patients who do not have manual dexterity. This is called a semi-rigid pump, and it doesn't have the pump component like the rigid pump. So with this, it's placed in a similar fashion. It's put into the corporal bodies, and then it's flexible. So here the surgeon is demonstrating how it works. So when the men are ready to have intercourse, they just straighten it, and then when they're done, they just then fold it down, like you see here, like he's doing. So it's a semi-rigid, and that's why it's called semi-rigid. Of course, the patients are not going to get the same level of erection and tightness as the rigid, but so this is usually reserved for men who don't have like appropriate manual dexterity to use the pump. And that's it. It's a short lecture. The question here is, how long do the intracorporal injections last? That's a very good question. I don't know the answer. Half-life of intracorporal injections. I imagine there's probably different formulations with different half-lives. So the half-life is 1 to 2 hours, and so 1 to 2 hours, yeah. Other questions?